Okay, I think we're good to start. So welcome everyone again. My name is Fernanda and I'll be the manager of today's webinar. It's a pleasure to have you here. Before we get started, we're gonna go through a couple of housekeeping items. So if you're experiencing any technical issues, please let me know in the chat box and I'll be happy to assist. As you notice, the session is being recorded, so this will be posted after the session in the website, as well as the slides. For questions, so if you have any questions, feel free to drop them in the chat box. Also, you're welcome to raise your hand. There is a feature at the bottom to raise your hand, so you can be unmuted and ask the question directly. And without further ado, I will just pass it to Javier.
Hello, welcome. Good afternoon, good morning, good evening to all of us. It is indeed a pleasure and privilege to have you here for the session of Associate Professor Joseph Dielman from Institute for Health Metrics and Evaluation, University of Washington. He is presenting a novel approach from the methodological perspective while estimating the value of healthcare delivery system using the data from America over the period of almost last 3 decades. So welcome to all of you. Thank you again. And please feel free to make the session interactive. Write your questions, observations, comments in the chat box. And when you write, please mark to everyone so that we do not miss. And at the same time, you are welcome to raise your hands. Clicking the icons at the bottom of your screen, you will find reactions. If you click that icon reactions, you will find that there is a possibility to raise the hands. When you raise the hand, then you will be unmuted and you can interact directly with Joseph Dielman. We take the questions at the end of the sessions, but in between, please keep on writing your questions against every slides or every presentations, every talk, so that we can comprehend or cluster your questions for Zoe to respond at the end of the session. However, at the end of the session, you are also welcome to raise the hands and speak to Zoe directly. Thank you very much. Now I request Zoe to take the floor and begin the session for the day. And this is the last webinar from Health Systems Efficiency Group of AHIA in 2021. And I also request Zoe to begin the session with a brief introduction about you. Zoe, please take over.
Great. Thank you, everybody. Thanks so much, Pavita and Fernanda for organizing and making today's session happen. Nice to see some familiar faces, or names at least, on the screen joining. It's a real privilege to be able to present today. My name is Joe Dielman. Like was said, I'm an associate professor at the University of Washington and work most of my time at the Institute for Health Metrics and Evaluation, which is independent health research institute within the university. And I, maybe as a couple of quick words of background, I guess I kind of consider the Institute for Health Metrics and Evaluation to be an institute that really focuses on global, but also local issues, and really maybe prides itself at working at the intersection of quantitative methods and health metrics. So designing metrics, evaluating metrics, doing forecasts, as we're probably most famous for at the moment, related to COVID. And of course, there's a place for health economics within measurements and within quantitative methods. So for me, it's been a great home, somewhere I've been for the last 10 years already. So I'm indebted to the team that I get to work with at the Institute for Health Metrics and Evaluation. I lead what we call the resource tracking team. which is about half global products, thinking about global topics. We do a lot of work tracking development assistance and government health expenditure for specific health focus areas. For that work, the unit of analysis is normally the country. And so it's, large global analyses. And then the other half of our research team, the newer part, really focuses on the United States. And we have work that looks across the US states, we have work that's national, and we have ongoing work that focuses at the county level. And I guess the most important thing is to thank the great team that I get to work with at IHME, the people that have really contributed to this work is Mita and Emily, as well as Haley and Sawyer most recently. And then I also, this work, at least the genesis of this work was funded through the Stanford Clinical Excellence Research Center, and there was a lot of great collaboration with Arnie Milstein and Kevin Schulman there as well, so indebted to them. I'm going to kind of think of today's talk in three parts. I'll spend the most amount of time on the first part, a little bit of time on the second, and then, I guess the discussion is for whatever time we have remaining and whatever questions come up. To get started on the part that we've done already, this is where I can speak with a little more probably precision, because it's something we've studied a lot. We published a paper in May of this year, and a lot of what I present today will build off of this paper. So that paper was in Health Services Research, and the paper itself had really two objectives. And the two objectives, the first was to kind of pose the question. This was the challenge kind of put forward to us by the Clinical Excellence Research Center, was across states, can we use state heterogeneity to make some sort of evaluation of health system value? And using as much data as necessary, could we come up with something kind of novel? And of course, there are some estimates of this, but by and large, they're not tremendously empirical or comprehensive. So our first objective was to just do that, was to come up with a measurement of value. And I'll spend a fair amount of time this morning talking about that. And then, of course, the very interesting thing from a policy perspective is to say, well, what drives policy? Or sorry, what drives value? And so that was really the second part, was not so much a causal analysis in any way, but more to just maybe explore the tip of the iceberg, which are what are the health system characteristics that were correlated with our measure of value. And maybe the last thing to stress on this slide is, health system, of course, is very large. And so we ended up deciding to focus much more on essentially the kind of the treatment arm of the health system, or the delivery system. So once someone is sick, the ability to care for them in an efficient way. And I'll talk at the end how in some ways that's very, unsatisfying. It's a corner of the healthcare system. It's probably in some cases the least efficient part, of course. And so one of our objectives moving forward is to expand that. But right now, really what I'll be presenting on today is a metric that's intended to measure the ability for health systems in the US to treat people, the delivery system ultimately. So we kind of started with a very basic, and these slides in some ways are intended for diverse sets of audiences. But, we started with a kind of a very traditional, simple concept, intuition of value, which is not unfamiliar to anyone here, of course, with the idea of saying, okay, well, let's start by thinking about health outcomes and resources spent. And so, for those of you that aren't based in the US, or haven't spent much time here, it's probably important to recognize that the US states are tremendously heterogeneous. They have a lot in common, I'm sure, but when I am sitting in Seattle, Washington, there are parts of the US that feel, quite foreign in some ways. And most importantly, the states tend to have distinct health policies. And of course, populations as well. And so one of the results of that, of course, is that if you look at health outcomes, there's actually a huge amount of variation across US states. And so, you know, the orange or red figure on the left is looking at health amenable conditions with disability adjusted life years. So it's essentially just looking specifically at 32 health conditions that physicians have decided, you know, shouldn't lead to mortality and morbidity because they're very treatable. And we see that really there's a huge amount of variation across the states, with states like Mississippi, Alabama, Louisiana, and in the South having almost double as many disability adjusted life years when looking at these health conditions that, again, should be amenable to healthcare. And then on the other, the green map, of course, we see spending is enormous range and a huge amount of heterogeneity. And so these are 2014 estimates, which are the most recent available produced by the US government with a CMS that has a state health expenditure accounts. And so this in 2014 essentially shows the range from, you know, about $6,000 to $12,000 per person per year. So again, not unlike the health outcomes, essentially a doubling when you look across the states, the range, the magnitude. And so, you know, the objective of this study was to just put those two together, to say, okay, well, let's, at a population level, let's look at outcomes and look at spending. And of course, and back to the objective, really focus on delivery systems and ability to treat using kind of population health outcomes. And of course, you know, the huge challenge here is that, you know, the variation across the states is not just in outcomes and spending and health delivery systems, but there's quite a bit that's different across the states. And so the underlying health of the population is very distinct. And if our objective is to really hone in at the delivery system's ability to provide care and value, we really want to abstract from or control for, you know, essentially the disease incidence, that's prevention, as well as age, and then things that we believe exacerbate healthcare, exacerbate health, you know, in adverse health conditions, things like body mass index, smoking, lack of physical activity. In general, I think we see as proxies to more severe illness. And again, if the objective is to, you know, hold a you know, a yardstick or meter stick up to the healthcare delivery system, we really want to first remove the impact of those things that, again, across the US states do vary dramatically. In addition, we want to remove things that we believe are associated with demand of care. And so we, you know, in this case, we've looked at income and education, race and ethnicity, and try to condition or control for those. And then finally, the cost of living varies dramatically across the United States. So, you know, we wanted to control simply for economy-wide prices. And it's important to recognize, in this case, I don't mean controlling for healthcare prices. What we want to think of is the, you know, opportunity cost of spending $1 on the healthcare system and where that money could go if it was spent locally. So again, it's not controlling for different prices in the healthcare system so much as controlling for the cost of living and prices on a broader basket of goods. So the goal, back to kind of the objective, is just to kind of hone in on healthcare value after kind of removing the impact of these things, looking at outcomes and spending. And so, you know, the overarching kind of analytical strategy in words, I'll show some equations in a moment, but in words, you know, the kind of when we sat with a whiteboard and kind of thought about how we want to approach this, the first was, well, we want to control for all of these factors first. We think spending and health outcomes, as you know, Porter and many have suggested, are the kind of the backbones of value. But we first need to remove things like disease incidence and age and prices and demand for healthcare. So that's kind of the first step. Then the second is, you know, we want to, what we're left with, the residual in some ways after controlling for much of that, you know, can be thought of as, you know, variation around, the standardized mean. And we can also then think about kind of a one-sided residual that is, a proxy for inefficiency. And so we use some kind of novel approach to frontier analysis and measure, again, after controlling for the factors I've mentioned, measure inefficiency for each state year. And then lastly, we want to, just use simple regression analysis to test the health system characteristics that are associated with value. So just to be clear, I'll kind of walk through these 3 steps today. And so if you kind of keep them in the back of your mind, is step 1 is intended to control for things that are really outside the purview of the delivery system. And then number 2 is to measure efficiency or inefficiency. And then number 3 is to essentially measure the association of our measure of value with these other characteristics. And the rest of the slides will kind of make more sense. So, the first part, and I'll show data in a moment, but the first part, again, where we kind of conceptually were thinking about what we wanted to measure is based in a frontier analysis. And the first thing that we wanted to do, and we kind of thought again about treatment, is to think about the mortality incidence ratio. So the idea is like how many people died relative to how many people got an individual disease. And so this is at the disease level, and we use data from the Global Burden of Disease Project on 135 health conditions that are prevalent in the United States, such that the numbers were sufficiently large, and we felt like we could, the measurements were high enough quality to incorporate. And we had measures of mortality and disease incidence for each state and each year of the study. And so in the equation, I is US state, T is time, and at this point, the analysis extends to 2014, but I'll talk about how we're extending that. And then from that point onward, it's kind of a frontier analysis with X being the control variables that I already mentioned. And then innovation here as far as the frontier that we're using is based in splines instead of a kind of predetermined functional form. And so that that means you don't have to choose, Cobb Douglas or something else, and instead can really let the data drive the shape of the frontier. And then after that, it really is kind of a traditional stochastic frontier analysis. And so to speak a little bit to the data, the dependent variable of these 135 different models to run are cause-specific mortality and incidence ratios. So again, this is measured by state. I guess we censored the very top age groups from the data set, from 75 and above, with the idea that, again, we're really trying to standardize the healthcare system's ability to treat and evaluate it. And so looking at the highest age groups, it just felt like there was more noise there. And of course, age and severity maybe has the largest impact there. So we're really focusing on ages 0 to 74. We've taken out year effects, so time trends essentially, and with the idea again of, we're not so interested in value over time. We're really in this study interested in value across states. And then the dependent variable of most interest is healthcare spending. So the state health expenditure accounts is produced by CMS. Currently, they have estimates from 1991 through 2014. And so initially, that was really the constraint for this analysis. And when we, to be honest, when we went to publish it, some of the feedback we got initially was, well, 2014 is ancient history. This is an interesting academic exercise and a novel approach, but the outcomes, the measurements are not of tremendous value. And so that's something we've been thinking about a lot because our estimates, like I said, only extend to 2014. And then our controls are here and lower than that. The last set of the slides. So we try to control for age, income, education, obesity rates, smoking, race, and physical activity. And you can see in the parentheses, we have a prior on each of these. And I will essentially, I'll kind of talk through how that was implemented in a moment. But the idea is something like, an older population leads to a higher mortality incidence rate. Again, with older population kind of being a proxy for severity and frailty of the population. Whereas income, we expect to lead to lower mortality incidence ratios, with the idea that wealthier populations have more access to healthcare, and if anything, are probably able to diagnose diseases earlier, and therefore the disease incidence is of lower severity because it's been diagnosed earlier. So you'd expect the mortality incidence ratio to be lower, and I think the rest are relatively straightforward. But of course, the choice of controls is hugely important in this topic. For those of you who've worked extensively with frontier analyses, know that the frontier is in some cases quite fragile, or shifts around depending on what controls are included on the right-hand side. And so for our analysis, we did really, I believe, close to thousands of sensitivity analyses with different sets of controls, essentially just varying the sets and ensuring that our results, the key results, were robust to the different inclusion of controls. And of course, what we found is that the measures of individual state value did shift around, but the general ranking was relatively correlated, and some of our conclusions related to health system characteristics were very robust. They didn't go away with any of the shifting based on controls. So this is my one slide that I will put up that maybe is meant to whet your appetite on a tool that IHME has developed. It's actually in its second generation currently. And if you have interest in this, I'd be happy to put you in touch with the applied mathematicians that have built this tool. I believe it runs most recently in Python, although I think there's a wrapper that it also works in R. At least there was for the first version, which is what we used for this paper. But the idea is that it's very similar to traditional stochastic frontier. The optimization is a little bit different, and again, that's kind of the math I didn't include here because it really takes an applied mathematician to understand the nuances of it, and it's not my expertise. And so I'm happy to put people in touch with the folks that I get to work with that are the applied mathematicians that have built this tool. But the thing that I appreciate about it in particular is the second bullet point related to the shape of the frontier. Again, it uses a spline. And so you don't transform your variables in any way, or at least spending and health outcomes don't need to be transformed in order to maybe capture the shape of the frontier, because it is very nonlinear. And again, there's kind of search parameters to hone in on the right number of knots. And you can provide linear constraints at the ends of the splines if you're extrapolating in any way. So it tends to be a very versatile tool. The other advantage is that you can put priors in about all of the parameter estimates. And in our case, we generally didn't utilize that. The one place we did use priors is that selection of covariates. And so I identified, on the last slide, the plus and minus kind of indicating the prior that we had of the directionality. And if in the frontier analysis, these variables were not statistically significant in the right direction, then we held them out. And just to remember, we're running this regression 135 times, once for each cause specific mortality incidence ratio. And so I do have some graphs that show the kind of the inclusion rates for all of these, but most of these were included in most of the regressions, but not all of them. And in particular, we generally didn't include income and education at the same time because they were just so correlated. but in general, the rest, the prior seemed to work out. And if the prior was violated, then for any one cause, we pulled that variable. That was kind of our search algorithm. So kind of very simple, I guess. So the last cool feature to the IHME SFA tool is a trimming feature, which again, we didn't use for this analysis, but it's an ability very simply to just trim a certain amount of the data. Essentially, the outliers you can choose if you want 5% of the data to not be influencing the shape of the frontier. So, if you believe that the frontier shouldn't be driven by the outliers, of course, you can trim out 5% or 10% of the outliers. And again, it has a pretty robust kind of search algorithm to identify the outliers. Again, not something we used for this analysis. We did play with it and kind of found that it didn't change our kind of ordinal ranking of our measures of value dramatically. And so we didn't feel like it was necessary. But again, an option for other use. So this is kind of an example. This is lung cancer. Probably important to look at the dots. We put a line through it, but as I was finishing up the slides last night, it dawned on me, we really use the dots, not the lines on the figure on the left. But this is a mortality incidence ratio over time for, I think, just a random sample of states, which is to show that, there's a pretty dramatic reduction in the mortality incidence ratio of tracheal, bronchus, and lung cancer in the US over this period. And, especially if you look at the dots and not the lines, you see that states are making progress on the treatment of lung cancer at slightly different rates. The lines are in some degree quite parallel, but the dots, show that there is heterogeneity. States make progress relative to others and lose progress. So that's the dependent variable, just to be really clear on what we're looking at, the dots, not the lines. And then the right-hand side is just an example of one of the frontiers. So again, we did the frontier 135 times. The y-axis, once for each cause-specific mortality incidence rate. The y-axis is kind of meaningless, at least I think it is. It's the adjusted mortality incidence ratio after taking out the impact of our control variables, right? So I think we would all kind of understand what a mortality incidence ratio is and what the scale should be. But this is after essentially differencing out the estimated effect of those control variables in order to be able to see the frontier really just mapping mortality incidence against healthcare spending. And you see, not the prettiest frontier, but here, of course, the inefficiency is above the line, above the frontier, with the objective of reducing mortality incidence. And each one of the dots, the blue dots on the figure on the right, is just a state year. And so you can see, of course, some states in there, dots going across time. You can kind of see in your mind that that's probably one of the 50 states. But in general, that distance from the frontier is what we're measuring as the inefficiency. And so just to be really clear, we are measuring, the distance from the frontier after removing the estimated residual and the other effects for each state year for 135 health conditions. So at the end, we get 50 states, roughly 20 years, and 135 measurements of inefficiency for all the major 135 health conditions that are relevant to our study. Here's opioid use disorder. I just pulled this one out because I think it's tragic and interesting. It shows the opposite as far as improvements in the mortality incidence ratio related especially to lung cancer. For opioid use disorders, we see that there's been huge increases in mortality incidence. Essentially, the severity of the disease or the condition and disorders has gone up dramatically in the U.S. Now, almost all the other mortality incidence ratios are going down. This is one that is going up because of opioid use. And the other kind of interesting thing about this slide is that the frontier is essentially flat. which is to say that healthcare spending, this is, across the entire healthcare system within the state, not just on opioid use disorders, doesn't have much of an effect, right? There's, as you spend more, you don't have a meaningful reduction in mortality incidence from opioid use disorders. And I think that kind of fits my intuition. Better operating healthcare systems and delivery systems are not necessarily in the US succeeding at driving down the mortality incidence from opioid use disorders. If anything, it's a lot of factors that are outside of the health system. So here's the frontier for the six diseases that lead to the most mortality in the United States in 2014. So opioid use, is on that list. But other things like ischemic heart disease, COPD, types of cancer, really jump out as the things that are leading to the maybe the most mortality. And again, there is the number of dots here is, essentially 50 times 20. So David, did you have a comment you want to jump in with?
Yeah, I think this would be a moment. I don't want to have to come back to this slide. I wanted to have you defend the skeptics' view that what we're seeing is the common time trend between spending and mortality. What about your method defends against that claim?
So in some ways, there is a common time trend, except for it's discrete for, it's going to be distinct for each states, right? The growth rates are distinct for all the states, and in spending and in the mortality incidence rate. So I guess in some ways, in one hand, we've already demeaned by year. So any sort of like idiosyncratic shock is more or less going to be taken out. But I still think we can see the clear time trend that is still relevant here. My thought was there's enough heterogeneity in the spending growth rates and the mortality incidence growth rates that there's still something valuable here. Are you saying that the frontier itself is just a function of time and not?
Yeah, that's, I wanted you here to say something like everything is detrended, and maybe I missed that part. If there's no time in this model because it's been taken out of the spending and taken out of the mortality series, then you're good.
Yeah, so we have detrended the mortality incidence ratio. I don't think we've detrended the spending, which I appreciate the push on and is something we could easily explore. That's a helpful push. We haven't done that, but we have detrended just demeaned across time the mortality incidence ratios.
Did you try case fatality ratios? I'm looking at for instance, the tobacco related.
Yeah.
And the health system saves you after you're sick, and you're getting a lot of credit for people just not getting these cancers. And that is probably not a whole lot of what the healthcare, curative people are doing. They're a little bit of cancer prevention, but that's really other out in society and social determinants.
Yeah, so I'm being a little bit sloppy. We use mortality incidence in conditions where it makes the most sense to do mortality incidence, and we consulted with medical doctors on when to use incidence versus prevalence. And then we use mortality prevalence in some cases. And so many chronic conditions like ischemic heart disease, it's actually mortality prevalence that we are assessing here. For the cancers, we use mortality incidence. For the injuries, we use mortality incidence. Opioid use disorders, we use mortality incidence. It's really the chronic diseases that we switch over and use mortality prevalence. And the rationale that we used when we kind of consulted folks on this is the course of care a function of prevalence, or the course of care, the course of treatment, a function of incidence. And so something like cancer, of course, there's a huge amount of heterogeneity across the cancers and across individual patients. But in general, the course of treatment is a function of when you got the disease and what you got. Where something like ischemic heart disease or COPD, it's less about when you got the disease. It's more about, do you have the disease? And now we're trying to treat it. So that was kind of the way we approached that. But again, you're right to say that prevention is essentially completely abstracted from this analysis. We know that there's spending on prevention, and you'll get, when I get to the kind of next step slides, you'll see that that's kind of number one on the list, is to incorporate prevention in a more meaningful way. We know anecdotally that most of the $4 trillion of spending in the United States is on treatment, but certainly there's a meaningful share on palliative and prevention as well. And we're including, just to be really explicit, we're including the spending on those things. We haven't been able to difference that out, but our dependent variable really is kind of abstracting from that, because we're looking at mortality incidence once the disease is contracted. So thanks, David, for the questions. The second part, just to keep moving quickly, is, so now we have for every state and year, we have 135 health condition inefficiency measures for each state and year. And so we want to bundle those up into some, meaningful metric that we can evaluate, that we can put on a scorecard. And so there's all kinds of different ways to do this, and we explored quite a few. Most of them are pretty correlated with each other. The thing that I think was most important that we chose to do was that we weighted based on the national mortality rates. So essentially, things like ischemic heart disease and COPD and lung cancer, things that lead to a lot of death in the United States, were prioritized in the way that we calculated our value measure. And so you see that, and things that lead to much less mortality have are down weighted ultimately. And that's critical, of course, because if all the states are doing a really good job at treating this disease, in some ways we should give everyone credit for doing a good job, but that would of course lead to lower mortality, and therefore it would be less weighted on our index. And there's a good argument for that. We chose to do the opposite and just really prioritize the diseases that lead to the most deaths. So the things like COPD and liver cancer and ischemic heart disease, that out of our 135 are, in some cases the most prevalent, but certainly the most fatal as far as total numbers of deaths is concerned, and honed our measurement in on that. And so this is some of the, this is published in the paper that came out in May. This is across states. Here, healthcare value is blue, and and it's scaled to 1 to 100, and reds and oranges are worse. Alaska's at the bottom. Right away, folks that are very familiar with kind of thinking about health system value in the United States, kind of raise maybe an eyebrow, like, Florida, really? That doesn't sound right. Most times you read in Health Affairs or a similar journal about Florida and healthcare and value, it's kind of saying the opposite. And so we kind of put together this slide or this kind of figure to highlight, why we don't think our metric is total garbage. It's got imperfections. I don't want to suggest otherwise. But the idea of this table is it's just looking at the 5 states that we ranked the highest in 2014 with the most value. Again, that's just a weighted mean of these inefficiency scores from the nonlinear frontier on mortality incidence curves. And then the 5 states that are the worst. And it kind of passes the smell test, at least to us it did, and I guess the peer reviewers it did as well. If you look in general at the states that had the highest value scores, in between 81 and 77, they tend to have lower mortality incidence rates when you look at these 6 diseases that lead to the most mortality. And at the same time, those states tend to spend a little bit less. So I just took the median across the top 5. And you can see that the top 5 highest value, according to this metric, is spending $1,000 less per person. This is after adjusting for prices in the area. And generally, so they're spending less and they tend to have slightly better outcomes. They have lower mortality incidence rates for pretty much all of these diseases, these top 6, and we can look at top 10 or top 100 if we want. But you tend to see a trend here that the states that we have measured as having the higher value numbers tend to have lower spending and in some cases much lower spending, and then kind of mediocre outcomes, or in some cases really good outcomes and maybe mediocre spending, something like New York. But in general, the kind of combination of the two, it kind of makes sense. And then you see a state like Alaska at number 50, which after adjusting for prices spends quite a bit, about $10,000. This is again 2014. And their outcomes tend to be worse, in some cases dramatically worse than many of the other states. So again, I think kind of the thing we're trying to pull together is using this broad set of diseases, 135 health conditions, that again are weighted towards the most fatal, highest death rates, highest deaths, not death rates, excuse me, and also spending at the same time. And so you can see time trends as well. Probably the most important thing to highlight for this slide is these are ranks now, and you see really large uncertainty intervals. And I will come back to that. And I think, again, that's one of the major limitations of where the study is at right now. So, we say New Jersey's number 1, but in our confidence interval, it spans anywhere from 1 to 8. Or Washington, the state that I reside in, we say it's 15, but it could be anywhere from 9 to 22. So again, from like a scorecard perspective, the ranks are an oversimplification of the clear level of uncertainty that does exist. But you can see time trends. And when we've talked to people, we've asked, we've kind of dove into specific case studies and asked the question of, do these time trends make sense? And when we've talked to leading health experts in certain states, we've really focused on 3 states where we kind of knew people that we could ask questions who had a good 20-year perspective. We got really positive feedback that it made sense. I don't know if that's confirmation bias or not, but folks in California, Washington, and Utah in particular all kind of looked at the trends of their states relative to other states and felt like they made some sense. So the last step is then to just look at health system outcomes, or sorry, health system characteristics, and to see to what degree they can predict value. And so we use a simple fixed effects equation. There's no controls here because we kind of believe that our value measure is already controlling for many of the things that we would have controlled for. And so we essentially see this as an exploratory study. So we just kind of ran about, I'll show you in a moment, about 15 different fixed effects regressions. We kept them all separate because they're independent from each other, because number 1, a lot of these things are correlated, and number 2, the time periods that we have data vary dramatically. And so some of the characteristics, for example, we only have 4 or 5 years of data, whereas others we have, a full 19 years of data. And we didn't want to limit the entire analysis to the intersection of the data availability. So, so these are fixed effects regression. Each line is essentially the estimated coefficient, and they're all independent from each other. And so I kind of bucketed them into categories. And so, I think one of the things we thought was most interesting from the study's conclusions was our measure of value is indirectly or inversely associated with market concentration of providers as well as insurers. And so again, this is some of the data that's the weakest. Going through 2014, we only had 5 or 4 years on each of these measures. And of course, we're looking at variation across time because we have state fixed effects in here. But it's it does still see this kind of association that I think we would expect. We looked at insurance coverage and didn't find much. We did find that greater rates of Medicare Advantage enrollment. So the fraction of the Medicare population on Medicare Advantage was slightly, just barely associated with value of our measure. And then we looked at some Medicare, Medicaid, and then provider density and utilization figures. And again, they kind of all pass the smell test. They make some sense. We see that essentially increasing eligibility leads to higher value for some of the Medicaid variables. Same with drug plan premiums, reimbursement rates. Higher reimbursement rates lead to lower value. And then hospital utilization and hospital density in particular led to lower value in our measure. Again, lots of caveats there, but this is kind of the associations that we were walking away with. So we did a ton of sensitivity analyses, and if you pull up the methods appendix to the paper that's published in May, all of these, are included there. Except for this last hollow bullet point. This was something we got feedback from afterwards, after the paper was published, but we were able to explore and have made graphs to show that our measure is not sensitive to coding intensity. But by and large, while there are shifts in the relative ranking a little bit, the regression results hold steady. And certainly the value measures are heavily correlated across the different sensitivity analyses. So when we include things like population density, or we switch from income to education, or when we use all the covariates rather than using kind of our kind of imperfect selection tool based on our priors. If we adjust for medical prices, the best we could do here was medical salaries across states. We still get the same relationships. And then also in the appendix of that paper, we compare against, some of the other, really all of the other that we could find measures of state value. There's a lot of measures of value that aren't state oriented. We focused, of course, for the study on other measures of state value. And we found about a half a dozen that exist and showed how ours are related. In some cases, they're very correlated. In others, they are quite a bit different. And, and that goes back to things like Massachusetts, which we see as a relatively low value state in our analysis. And that's because they spend, much more than the mean on healthcare spending per person. And they have kind of, good but not great outcomes. And then the same is true, especially after you've controlled for income and some of the other controls. Something like Utah, for example, is another example. Utah is known to spend very little on health in the United States and has quite good health outcomes. But after you've controlled for age of the population, smoking rates, BMI, age and whatnot, and income for that matter, all of a sudden Utah looks a lot like the rest of the US states in that they, again, after taking out all of those kind of positive contributors, it's a much, not to judge anyone in Utah, it's a quote, easier environment to provide delivery of care because the population in general has less severe illness or is more educated or lower BMI, that sort of thing. So what are we doing? I'll rush through these because I do want to leave a few minutes for questions. I think I was told we can go to about quarter after the hour. I know it's late in Asia, so for those of you joining from there, I appreciate it. Kind of real quick understanding of what we're doing. The first thing is trying to socialize these estimates and get feedback on them. I, for a while, felt like I was on a little speaking tour because, they are controversial and they are distinct and different. People are, many people in the healthcare system have almost violent reactions when we say, oh, Florida has, pretty good value. And of course, you need to take that with a grain of salt because they're saying, well, if you control for the fact that Florida is the oldest state and they don't spend actually that much on healthcare, and they have relatively high BMI and low physical activity rates, in our world, they actually have okay value, pretty good value, actually. It surprises a lot of people. And when you say Massachusetts has mediocre value, again, it kind of flies in the face of what a lot of people expect. But the reality is they spend more than most other states, and their outcomes are good, but not amazing. And they're dealing with a population that's educated and tends to be lower BMI, higher physical activity, lower smoking. So the first thing we're doing is socializing the estimates. The second is, we got a lot of pushback from anyone that remotely is interested in policy that, 2014 is just, ancient history. By and large, we don't see any sort of meaningful outcomes associated with the Affordable Care Act really taking off as far as, Medicaid expansion and lots of little pieces went in, but not a lot of time trend to see the effects of that. And so our first step was to say, well, we went to CMS and said, when are you going to come out with newer state health expenditure counts? And it didn't seem to be imminent. And so our first step is to just kind of to try to forecast or estimate state healthcare spending from 2015 to 2019. We've done that. I'm not going to spend a ton of time on it, but essentially we went and used the data that CMS uses to do their state health expenditure counts. We couldn't perfectly replicate the methods that they do. This is work that's under review currently, so I'll show a couple figures, but it's not published, so there's nothing really to cite yet. We essentially tried to replicate to the best we could. We realized we couldn't perfectly replicate the estimation that CMS had done, and so essentially we ended up moving towards much more of a data machine learning kind of approach, where we essentially just looked at about 50,000 linear models and ranked them all on out of sample root mean squared error. So essentially we used data through 2000 to predict 2011 through 2014. And at the same time, we also used data from 1995 to 2014 to predict backcast 1991 to 1994. And what you're seeing here is out of sample predictions on this figure for, each different color is a state. It's broken up by region. And, we essentially just kind of threw the kitchen sink at it. Again, kind of more of a, not so much of a theoretical economics analysis and more of just a prediction exercise. And again, used out of sample validation to prevent any sort of overfitting. And the 150 here is reflecting of all of what we explored. We felt like our estimates are not perfect. We have better figures of this that actually incorporate our measures of uncertainty. But in general, we felt like, while we couldn't perfectly replicate what CMS was doing, we could, especially within our measure of uncertainty, more or less statistically replicate it. We also did this analysis by payer and type of service, which is how the state health expenditure accounts reports. And so you can see we did a much better job at like Medicaid spending, where the data is a little bit better, Medicare spending, where the data is better. And once you get to commercial and private insurance, we struggled quite a bit more. So this is in fraction space. So, these are meaningful differences. Either way, this is what we came up with. Again, the paper's under review currently, but we essentially brought our estimates through 2019. We did some kind of interesting standardizing analyses, which I won't have time to go into today. But really this, slide, if anything, is to suggest that there's still a huge amount of variation in healthcare spending in 2019 using the input data that we had available to us, which is more or less the same data that CMS uses for the official records. We see that Alaska still spends close to the top. So does District of Columbia. Massachusetts is towards the top too. And states like Utah and Arizona and Georgia spend substantially less. And again, we did this by type of service and spending by payer. You can look at growth rates, which are kind of interesting. Right now there's no comprehensive state measurement across all payers of spending by states. So this is just breaking the 50 states into kind of three categories: Medicaid expansion, no Medicaid expansion, and then kind of the people in the middle that did do Medicaid expansion, but relatively late. And so if you compare the kind of dark blue and the red, that's the differences in Medicaid expansion. You can see where the states fall in the box of whisker plots. Most critically, you would expect Medicaid spending went up dramatically in the states that expanded and went up less in the states that didn't expand. And then similarly, the out-of-pocket spending went up more in the states that did not expand and less in the states that did. And same with private insurance, a little bit, but again, not a huge amount of variation across the states. We reran our value measurements, and I think probably the most important thing, and the reason I included this is not under review, this is still a work in progress very much, is to see how much of a shift there was. So this is 2019, and I showed before 2014. And we see pretty dramatic shifts. And I think we've explored that a lot, or in the process of exploring that. And we've identified, sure, these, just like before, the ranks change over time. We see that. And there's, but probably more critically, there's a huge amount of uncertainty. And so we're really trying to understand where the uncertainty is coming from. We have incorporated uncertainty in our dependent variable. The mortality incidence estimates are estimates, so they have measurement error. And so we incorporate that. But there's also a lot of error, imprecision, I should say, from the frontier analysis. And trying to improve those models is important. And then, of course, we include the uncertainty of our forecasts of the healthcare spending through 2019 as well. And so that's not shown on this slide, but there is a fair amount of uncertainty by the time you go from the official estimates in 2014 to the final estimates in our estimates of 2019. There's a lot of uncertainty there. So the other things that we're doing on this work related to value is we're trying to do just that. We're trying to reduce the uncertainty, try to improve our methods. And then feedback we've gotten from a lot of people, of course, is that the prevention is a major part of the health system. It's not just about public health initiatives, which is a very small part of the budget, but it is the maintenance and prevention of diseases is real, especially some of the chronic conditions, and to try to capture that more seems important. So essentially, pre-incidence, pre-diagnosis, what could we measure, and so we're trying to incorporate that. The last bullet point that's not on here is, we have a pretty coarse measure of spending. And so we are just looking at total spending by state. And what we'd really like to do is look at spending on ischemic heart disease relative to mortality incidence outcomes for ischemic heart disease. And we'd like to look at spending for lung cancer and outcomes for lung cancer. And so that sort of much more kind of direct connection as part of our long-term vision is that we really want to be tracking spending by disease across the states rather than just having total spending. So that's it. I will close the slides. I think we have 10 to 15 minutes for questions for people that are able to stay on. And happy to take questions.
Well, there is a Pretty Januar wants to have some interaction about inclusion of social determinants. May I ask Pretty to raise your questions to Zoe?
Thank you. Thank you for this wonderful presentation. So I was curious, first of all, what data was used for this analysis, and it seems that some of the work was published in Health Services Research, and in the same journal you see a lot of healthcare utilization has been the framework that they use is the Anderson Health Behavior Model, which has need factors, access to care, access to transportation barriers, or many other factors which are social determinants of health that can impact outcome, that can impact health survey use. They may even lead to delayed care and treatment, delayed diagnosis. So I'm wondering if depending on the data you have, it may or may not be possible to take into account, but what can you include to reduce the effects of those things?
Yeah, thanks, Priti. I agree completely. What we've included, is income and population density, and that's kind of the closest. Well, in education, I should say, but that's the closest we've gotten. I do think there is more data that could be put together at the state level that, like you said, would provide information about access to care. Population density, of course, gets at it a little bit, but when you're measuring at the state level, it's pretty coarse. And I do think we could build up estimates, at the county level, or even the ideally at the zip code level, that would look at access to pharmacies, access to primary care, and then we could condition on that, because really our goal is to look at, once someone is in the health system, how do they do? How is the mortality incidence ratio? Not about getting to the healthcare system. And so I do think it's important to take that out. There's a lot we so included race. That's very controversial to include race. Do you want to condition? Those of you based in the U.S., or probably all of you know, the U.S. Has major problems with systemic racism, and it is very prevalent in the healthcare system. That's something our team studies some, and I think there's a lot of good research on that topic, of course. The comment right there, that Priti, that you just put into the chat, is exactly spot on. It's not biological, so on one hand it doesn't make sense to control for. On the other hand, we know that there are systematic disadvantages to, in particular, people of color in the US accessing care, or even wanting to access care for that matter, because of past experiences. And so the question is, like, on one hand, do you want to control for those, recognizing that Black Americans may be slower to access the healthcare system for a wide variety of reasons, or do we want to not include that? Do we want to say it's the healthcare system's responsibility to be reaching out to all individuals, regardless of race and ethnicity? So again, the question is kind of, where's the onus? And we've done our analysis with and without race. And it does vary, because we know frontiers are sensitive. So yeah, I think tremendously important, and something we hope to continue to look at a little bit, but also controversial as well.
Well, now there is a question from Bill. How you have captured the different covariates, which is state specific, like the obesity rate, elderly population, smoking, and so on?
Yeah. So, the Institute for Health Metrics and Evaluation runs the Global Burden of Disease project. It's a global project. It includes, I think at this point, 6,000 researchers, a lot of epidemiologists. And so they have estimates that we've incorporated into our study. In the case of the US, that's primarily pulling from 3 different major data sources: the census data that including the American Community Survey, BRFSS, and NHANES, and all of those surveys, and maybe a little bit the National Health Indicator Survey, NHIS. Between that set of surveys, there's a fair amount of information about each one of these, the covariates that we've included, including the income and education variables, which come from ACS. So that's what we've used for our study. Again, that was kind of work done by a previous team, and we've just been able to kind of harness the estimates used. And then again, we do incorporate the uncertainty of their estimates from the surveys and from the meta-analysis that they've conducted to influence our levels of uncertainty. So it's partly why our measures of uncertainty get so large, is because a lot of our input data is measured with uncertainty, and then of course the frontier model has uncertainty as well.
There is another question from Anusri. She is asking, how we have captured the differential spending on information dissemination. And that also influences the consumption of healthcare services. Honestly, if you want to speak, you can raise your hand if I'm not right to present your questions appropriately.
Hello.
Yes.
Am I audible?
Yes,
Yep.
of course. Yeah, please.
Thank you, Joe, for the presentation. My question was, when government does spend on health, there's a portion. Since I come from middle income country, a larger portion goes into IC activities in terms of putting out advertisements or posters and things like that, which also have an indirect impact on your mortality rates, because HIV, a classic case is HIV AIDS, where a lot of advertisements were put in terms of protection and things like that. So in such cases, can we take this as a control while running the frontier analysis? If so, have you considered this element in your study?
Thanks, Anu. That's a great point. We have not included that, and I think we would like to. Just to be really kind of precise about our study, we're capturing total spending, which includes all of the spending on activities that you just mentioned. In the U.S., I think it's $4 trillion spent on health each year. The precise fraction that is on prevention and communication, where in this case prevention is considered really public health initiatives, is quite small of the 4 trillion. But I think the point remains, it does vary across states. And the people that live in Massachusetts and are mortified that they get a mediocre ranking in our system would quickly point out that one of the places that Massachusetts excels is some of the things related to child immunization and a lot of prevention work, community prevention. And of course that costs money, which is being included in our study, but it doesn't really generate outcomes that are included in our study, because preventing a case is kind of outside of our study. We're really just looking at the treatment of cases, and that's why I think when we come back and reevaluate the study and try to add to it, the objective is really to be able to incorporate prevention in some way. So.
Well, thank you. There is no more question. So if you're having questions or speak to Zoe on any matter, we are having few more minutes. You can raise your hands. Okay, then thank you very much. So we conclude our session, the last webinar for this 2021. And we will be welcoming to receive your suggestions about the topics for 2022. Please feel free to write email directly to me or Ahia office, mentioning your aspirations for 2022 webinar series from Health Systems Efficiency Group. So thank you very much. Thank you all of you, and have a wonderful festive season. See you soon again. Bye.
Thank you, everybody.